I'll introduce Professor Farida Fortune. She is the Professor of Medicine in relation to oral health and was head of the Centre for Clinical and Diagnostic Oral Sciences at Queen Mary University in London. She will be speaking about health perspectives and opportunities for developing countries. Prof. Fortune, if you would like to introduce your topic and start your presentation. Thank you.
Thank you very much, Prof. Adam, for asking me. I've had a most wonderful day so far, listening to everyone, and learned a huge amount. My name is Farida Fortune. I'm what's called a clinical academic, which means that I teach as well as do clinical work. So my university has been using online teaching for some time, and over the summer I just formalized it all, as well as using quite a lot of video conferencing. I also use some AI for my research to identify novel protein molecules. And the other thing was that I also run clinical sessions, and I've been working all through COVID. And I do appreciate that the people with transferable skills were the people who were most important in supporting the COVID initiative. So today I'm going to talk to you about global health perspective online learning in developing countries, but really it's about global solutions, but actually local delivery. And the huge opportunities for doing all of this, as well as huge risks, which should not be underestimated. And we have to always keep in mind that we who are in charge or run programs, never to assume that we know the best, but we should be able to deliver the best. And my huge thing is communities. And we must not forget communities wherever we are, whether we're in London or whether we're in Africa or Asia or Brazil, which I love, and which you do a great job. So I'm sure everyone knows this internet distribution. I simply wanted to show it to show the inequality of it, and that 50% of all the users of the about 6 billion now people who use the internet are in Asia. So China has over 1 billion users, and then India, Malaysia, Japan, South Korea, huge amount, North Korea, no one, and Indonesia, Malaysia. So all very big users of the internet and have moved forward with internet usage within their populations. Europe as well, their penetration is high, over 90%, and North America. Then when you come to the rest of the world, we seem to have problems. And it's a bit concerning that we're providing huge solutions who are amazing to people who don't have any access. And in 2013, I developed a process where we could be working in health and education to work with local communities anywhere in the world, but mainly with disadvantaged groups, to provide solutions that they wanted and they needed, and that we would put in place. So we've run programs all over the world, and as I say, mainly in the developing countries. Because this is the big thing, you know, if you don't have clean water, you don't have education, you don't have health, and you don't actually have access to any of the things we were talking about today. So how do we work with these communities, not from what we think they need, but what they tell us they need, and to empower them? Because if you look at the sustainable goals, for these groups, okay, we are not going to do anything. And I liked the slide earlier, which showed this poverty inequality around all the characteristics of the SDGs are not available. But if you give people health and education, you empower them and you motivate them. And I think the most important thing we are all going to need going forward is resilience. You need to build that resilience. And I'm not quite sure in some of our methodology where soft skills are not going to be so important, are we going to build resilience in our communities? One size doesn't fit all. You have to provide what works for a particular community. But my big thing is localism. You know, you help with a strategy, you help setting the objectives, but this comes from the local community. And you have to be aware of the environment you are working in, and so that you can make sure whatever project you do, whatever help you do, it works. And I know there's quite a lot of educational pedagogy, but actually basically for people like me, we learn really from what we see, how we interact with people, what we do, and what we listen to. So those things are really important and should continue. I don't mind what you call it, if it's blended, but you have to have a pragmatic approach. Take the best of what you have from where you are, get your group to define what they need and want locally, make sure, like the Brazil group who've done a fantastic job, that you've got something to evidence it, and then work. So we work with, so working together, a group of like-minded individuals. A lot of us are academics, diaspora, and other people who are not in the academic environment, and we work with local NGOs. All right, so although we work through the universities, the hospitals, with the local countries, actually it's the local NGOs who make the difference. And every project where we've succeeded was the local groups who are nimble, they can respond quickly because they know what is needed. And I always say, if you're going to be successful at anything, at the end of it, you have to stand away, walk away, and know the knowledge, the skills, and the leadership is with the local people, no longer with you. So I have this we can do, I can do, we can do mentality. You know, I know in Africa, besides the electricity, besides, you know, no money going into the important areas that they should, that people are hugely resilient. And actually, you know, there's no broadband coverage. People don't have money for that. The only thing that everyone has in Africa is a cheap mobile phone. Okay, so you use that. And actually there's GPS. So you take a mobile broadband and you take it on a car, you can take it on a donkey, and you can take it anywhere. You take it into the local university and you can take it into the local school. Actually, you don't need to be separated. Community is very, very important. If you're out in the open, in the veld, okay, you don't have to sit next to each other and you have broadband, but afterwards everyone can discuss and you still have the community and the interchangeable learning. And this has worked very well. We've uploaded programs from London. They're taken down by schools or universities and using them for teaching. We also use this when there's an operation and they need high-level expertise to guide them through operations where they don't have the money to take the patient out of country. That works well. So this is cheap, movable, and easy to use, right? And yeah, this is children who are heads of families or parents have died, and so they don't get a chance to go to school, let alone have a computer. So you can do exactly the same. They're taken away over a weekend and they have their education. And then you use all the forms of learning to try and embed in these children, build them with a sense of pride and proud of what they do, and use the skills of their mothering and fathering and bring that as a learning to the group. And when they're older, quite a few of these children have managed to get through school, managed to get through university. They then learn the other skills. This is my favorite slide. Okay, these two young children are under the age of 10, okay? Look what they've done. They've got almost nothing. Even to the marbles that they're using are the correct size to play pool. Now, this is a huge amount of learning that has gone into this, and these children have elementary school, and that's all. And I wonder if you see the King's Fund article last year, that's Independent Research Fund, saying London Calling, saying, why are we in our hospitals dependent on staff who comes from the low and medium economic countries? Why do we have such a lot of international recruitment of health workers? Okay. And why is there such competition? America, Canada, Europe, UK, Australia, all want the staff. And in COVID-19, if you ask anyone, most of the staff in hospital who died were the Black and ethnic minority groups, which a lot of them came from these countries. But actually, it's telling you a story that they have skills, okay, which are needed. So don't forget, when we're going and doing massive online learning, I'm not against it because I do it myself, but I think the transferable skills are hugely, hugely important. So just a bit about localism. We learned a huge amount with Ebola when people were dying. And we found out actually nobody could understand the 110-page WHO guidance book. So we took it, turned it into 10 pages, all pictures, and everyone in the group had to send it. We sent it to churches, mosques, schools, local community groups, football clubs, and pinged it into the countries, and people actually said they understood. Somebody told me from New York hospital, it's the first time I understand the guidance. So with COVID-19, we did exactly the same. We made really easy to understand manuals, which you could pull a page out and pin it on a clinic wall with a lot of guidance. And we made waterless soap, and then realized actually we couldn't send it in country. So because we have this really large network, we gave the recipe, the formula, so that they could use it, and it could be made, and it had to be distributed free. And I think that's really important. So I'm very keen, okay, that we reduce inequality. And it's there, all right, we have to do this. But at the moment, it isn't happening. We're in the middle of wherever we are, and so you have to adapt and deliver. You've got to continuously engage your partners And locally, there have to be active partners that you keep on talking to, where you know what they need and want, and build capacity. And this capacity about data collection is that really you know what needs to be delivered. I'm not keen on collecting personal data, as I do my learning at night, and I found out that actually every time I was doing some medical educational learning, the data about me was picked up because I didn't do anything for about 2 weeks, and the message came and said, this is your new learning, we haven't seen you. This data that I think we should collect is data that tells you what the needs are, so it can help you deliver. And really never believe that a few caring people can't change the world, because that's all who ever have. And so thank you, Professor Ella, who's the most caring person and who's made such a difference over this last year and during COVID, keeping all of this going. And there's large groups across the world, we've all learned loads and loads from each other. And I think your legacy is that a lot of us join up because we all have the same ethos of delivering. So thank you very much.
Thank you so much, Professor Fortune. Really, again, invigorating and interesting topic. I really particularly enjoyed the story of localism and how actually we can have this knowledge transfer from Africa and developing countries, and how we can learn transferable skills. And really there is an element of frugal innovation. I don't like the term reverse innovation, so I will go with frugal innovation, and that we can learn so much, especially with education and health. So thank you for that. And I would like to open up to questions, please.
Thank you for the wonderful presentation, Professor Farida. I have a quick question. If you actually, I wanted to, if you could extend a bit more when you say about the capacity building for data collection, and because this is we nonprofits talk a lot about, and how this can be then transferred or dialogue to, for example, the scientific university world, because still I think there is this, I wouldn't say gap, but the data collected by nonprofits that are usually used in program development or, as I mentioned, policy making, still is not seen or regarded the same as knowledge created by, universities or the scientific community. If you could spend a little about.
Yes, I mean, that's very important. If I give you an analogy in medicine, that we have something now called patient-reported outcomes. Previously, we only had physician-reported outcomes, and all policy was made on that. I run a rare disease, and we really needed to have patient-reported outcomes. I moved my focus to the patient-reported data. And that data has become so powerful because it not only tells you about things like diet, health, education, all symptoms, drugs, if what you're using is inappropriate or not. And it's only when you start using that data. So with our programs, the reason why we've kept it so local is we always have a very strong governance structure around data. So I haven't shown you that because we haven't had enough time. And Prof. Alam always says I talk too much. So, and so we have a strong governance around the whole project. So as soon as we start working with the group, we will put all the data that they, okay, want included. So that's taken in first, and then working together to put the project together, and the data then that comes out from them again. And so the data collection is really important. And then is once you have data about people, they should know exactly what data you have, and that data is fed back to them, or they always able to see it, right? And then the other data that you hold, you keep on adding to it. So if you'd gone back to the model that was set up, you'll see that wherever the data comes from, there's a central data bank. And we have somebody whose sole expertise is data collection, data security, and making sure that if you have data from someone, that they are aware of what the data is. We never collect the sort of data that tells you about people's habits or what they're doing, so private data. But we'll have a really good outcomes data of the needs, the requirements, and really how you input into ongoing with your project. And that's why we always know, that's how we found out that people actually couldn't understand what they were telling them to do. With Ebola, everyone thought it's because they kept on washing the bodies after they had died. But what they were saying to us, actually, we don't know what they're asking us to do. The paperwork is so long, so big, right? And everyone made an assumption, oh, people, because they're poor, they can't read. You know, there's a whole load of assumptions around people. But actually, it wasn't that. This document was totally incomprehensible. So, and that was actually this people reported data, as opposed to us saying, we want this data or that data from you. Yeah?
Thanks.
Great. But it's important to set it up and have it centralized and have a good governance structure around it.
Yes, I think that's the biggest challenge. Centralizing it, sharing it, or finding platforms to share the data and the research. I think a lot of NGOs struggle with that. It's a lot of education institutes as well.
I think it's because the other thing, it's the way people think about data. They think that if they have put it in from a higher organization, it's of importance, but this data down here isn't. But without this data, you actually can't move forward.
Absolutely, yeah.
I mean, we always make sure that in-country data stays in country, all right? So if you from, say, Botswana, Malawi, whatever, that's your data. You keep the data, right? We will pull towards the center, okay, but you will know everything that we see. And people don't see other people's data. So you're from another country, okay, so you're from Kenya, you see the Kenyan data, not the Malawian data.
Yeah.
Yeah.
And surprisingly, what I found in my research is that a lot of the issues are shared. So a lot of issues are transboundary. I did a bit of research into climate change, and we all face similar issues. So sharing the data would be so useful across countries, especially countries within neighboring countries.
Yeah.
So thank you so much. Thank you. Did you want to add something? I'm so sorry.
No, I just wanted to go into saying, and I was listening to Prof. Marabello this morning and thinking, that's the same where I come from. So I think it's all shared. We all have the same frustration, but actually it's to find a pathway under all of that you can still be effective.
Thank you so much. In the meantime, we
Yes.
do have a question, I assume to Professor Farida. I'll read it out. Thank you, Professor. The issue of health professionals from poor countries migrating to developing countries to provide healthcare to rich countries is paining. How can we provide decent pay to attract them back to help the most vulnerable and needy people in Africa? Professor Farida?
Yes, this is a huge problem. I've just replied that amazingly, without having IT training, but actually having good traditional maths in Africa, that most of the people in London for the big banks and big organizations are IT technicians that have come from Africa. So minimal learning, come in, able to work at a very high level. I think this is a huge problem. If you look at one of the African countries where they hadn't paid the doctors or the nurses for over a year, can you blame those people for their migrating? And what a lot of countries or the LMCs don't realize that their teachers and the people in health, the nurses, the technicians, the doctors, are really their most precious asset. And frequently people leave, not because they want to, they leave for economic reasons. And I think that's a real shame because, you know, you're just producing this wonderful asset and then it goes. And so that's why I think it's really so important that we work with diaspora over here to just try and give back. But I think that still doesn't beg the question of why. I mean, and it's, to be quite honest, it's the UK, it's America, it's Canada. They go and recruit, and I think it's a huge ethical problem that people should sit back and think about, which they don't. Really. But you know, but if you're not paying people, how can they live? They've got families, and if somebody's going to ask them to go, and we'll pay you and have a reasonable life for your children and have enough money to send back home, that's what's going to happen, which is a problem. I don't know, but I think that the governments from the very rich countries should also think very carefully when they go and recruit people. You know, I know everyone's health is important, but actually the health of people from the low and medium economic countries are even more important, I would say, because we still have access to healthcare and they have access to none. And if you look at most of these countries, you know, the medicine that has been put in place, almost all of it is by NGOs.
I want to ask as well, is it just the financial incentive that draws these people out? I also feel the level of education and access to resources, educational resources, medical facilities is also a massive issue that, you know, people want to learn what are the sort of groundbreaking new developments in their area and they're not getting access to that. So I think that's another issue, you know, if that was streamlined and improved, I think.
But we could do that, you know, that we could help upskill patients. I gave an example. They were going to separate Siamese twins, hadn't done the operation before. And so the surgeons spoke to them, planned it with them, and then had the broadband and gave access. So I think we could do quite a lot from here. And I think the one advantage of the online learning is that it's opening postgraduate training. However, it's not without expense. So if you look at all these Moodle courses or run by the big universities in Europe and in America, they're extremely expensive. And what they don't realize is that the people in the developing countries, that's more than 2 years worth of pay. So we have to, through NGO, supply that gap. And I think, of all the people that are here, we have those skills, and that's where the sharing should be. And if we do that, then people will not need to come here. I mean, we set up, we worked to set up a dental school, and there was only 4 people doing it. And then within 5 years, people qualified, got on the international register. They came here to do exams, but there's only 4 people out of that first lot of 20 who never went back. So I think it's really important, if you can provide, and it's in-house, then people always stay where they trained, right? If you take them out and train them elsewhere, chances are they won't go back. But if you train them, in their local environment, they will stay.
Thank you. Thank you for that point, and thank you for the question.
So please remember, if we all help and do a little bit, it will make a big difference.